Welcome back to the deep dive. Today, we are opening up a topic that I think it's fair to say suffers from a bit of a PR problem.
That's putting it mildly.
I mean, when most people think about this organ, if they even think about it at all, they think of plumbing. Pipes, filters, waste disposal, just a very utilitarian, unglamorous system.
And it's that plumbing reputation that really gets the kidney into trouble. It leads to this dangerous underestimation of what the organ is actually doing second by second.
Exactly. We are, of course, talking about the kidney. And based on the stack of research in front of me specifically, we're looking at Chapter 20 from Robbins and Tochin, Pathologic Basis of Disease, and Chapter 21 from Underwood's Pathology. We're going to have to throw that plumber analogy out the window pretty fast.
I would suggest we replace it immediately. Right now, don't think of the kidney as a plumber. Think of it as a master chemical engineer.
You're a chemical engineer. Okay, I like that. Let's unpack this right from the start.
Well, just consider the input. I mean, the human body is a fundamentally chaotic system. You drink a coffee, there may be a huge bottle of water, then later a glass of wine.
Or nothing for hours.
Right. You eat a really salty burger for lunch, then a kale salad for dinner. You run a marathon or you sit on the couch all day. The chemical input into your system, your blood, is just wildly variable.
Yet if I go and get my blood drawn today and then again next week after a completely different diet and exercise routine, my numbers, my sodium, my potassium, my pH, they're almost identical. Rock steady.
Precisely. That is homeostasis. And the kidney's job is to maintain that internal constancy, that balance, despite the absolute chaos of your lifestyle. It balances volume, electrolytes, acidity, all with a level of precision that is, frankly, just staggering.
And the silent master aspect of the title we chose for this deep dive, that refers to how quietly it does this incredibly complex work, right? Because reading through Robbins, the thing that honestly scared me is just how much damage you can do to this system before it ever complains.
That is the central tension of all of renal pathology. The kidney has an immense functional reserve. I mean, you can donate a kidney, literally give away 50% of your total renal mass, and live a perfectly normal, healthy life.
The remaining kidney just picks up the slack.
It hypertrophies, it gets bigger, it works harder, and your blood chemistry looks completely normal. Which sounds like a good thing, a great design feature.
Until you flip the script.
Right. Because it means that disease can be silently eating away at your insides, destroying nephron after nephron, scarring the tissue, and you won't feel a thing. You won't have pain. You won't look sick. By the time you actually have symptoms, what we call the clinical presentation, you might have already lost a massive, irreversible amount of function.
So our mission today is to map out that silence. We're going to synthesize the mechanisms of injury that are described so well in both Robbins and Underwood to understand not just what goes wrong, but why it goes wrong.
And just a quick but really important disclaimer before we launch in. This deep dive is a conceptual map. We are synthesizing two massive foundational medical texts here. Robbins gives us that incredible breadth and systems integration.
And Underwood gives us that mechanistic clarity, that focus on disease as a response to injury.
Exactly. So this conversation is designed to help you, the listener, visualize the logic and connect the dots. But it is absolutely not a substitute for cracking open the books themselves.
No, absolutely. You have to look at the slides. You have to see the histology for yourself. Think of this as the framework you can use to hang that detailed knowledge on.
Perfectly put.
Okay, so to give us some structure, the texts generally divide the kidney into 4 interdependent compartments. I really like this approach because, let's be honest, renal pathology can get messy fast. So we have the glomeruli, the tubules, the interstitium, and the blood vessels.
That's the basic structural framework. But there's a concept in Robbins that is just crucial to mention right up front before we go any further, and that's the interdependence of these compartments.
Meaning they don't stay in their own lanes. The problems bleed over.
They cannot stay in their lanes. It's impossible.
Yeah.
If you damage the glomerulus, that's the main filtration unit, you will inevitably reduce blood flow to the tubules that are downstream from it.
They get starved of oxygen.
They do. And conversely, if you damage the tubules, say with a toxin, they can get blocked. Pressure then builds up and it backs right up into the glomerulus, stopping it from filtering. It's a domino effect.
So regardless of where the disease starts, whether it's a vessel problem like hypertension or a filter problem like glomerulonephritis, if it's allowed to progress, it all converges on the exact same endpoint.
End-stage kidney disease. It's the destruction of the entire architecture. And at that point, the specific initial cause almost becomes irrelevant because the end result is the same. A scarred, shrunken, non-functional organ.
Okay, let's pause the dominoes for a second and look at that first tile. the functional unit of the whole system, the glomerulus. In the texts, this is described as a high-pressure sieve.
It's a tuft of capillaries, a little ball of them, but it's a very unique kind of capillary bed. In most capillaries in your body, say in your skin or your muscle, the blood pressure drops significantly as blood flows through. But the glomerulus is different. It's engineered to maintain a very high hydrostatic pressure, about 60 millimeters of mercury, all the way along its length.
Because it needs to physically force fluid out of the blood. It's like putting your thumb over the end of a garden hose to increase the pressure.
That's a perfect analogy.
Okay.
It's forcing plasma water through a filtration barrier. And this barrier, this is one of the most sophisticated and elegant biological structures in the entire body. Robbins breaks it down into 3 critical layers, and we really need to understand them to understand the diseases.
Right. Let's meet the guardians of the filter. Layer 1, the fenestrated endothelium.
So fenestrated just means it has windows. Think of this as the first, coarsest line of defense. The endothelial cells that line the inside of the capillary have these little holes, or fenestrae, that allow fluid and small solutes to pass through, but they are small enough to hold back the blood cells, your red cells, your white cells.
Then, outside of that, we have the glomerular basement membrane, the GBM.
This is a thick acellular meshwork. It's made of proteins, primarily a specific type of collagen, type 5e collagen, and proteoglycans. It acts as a much finer physical sieve.
I noticed the text really highlighted type IV collagen. That specificity matters a lot, doesn't it?
It matters immensely. There are critical diseases that specifically target that type of collagen. For example, there are genetic diseases like Alport syndrome, where you can't make proper type IV collagen, so the mesh is weak. Or there are autoimmune diseases like Goodpasture syndrome, where your own immune system makes antibodies that attack it. If the mesh is weak or under attack, the whole filter fails.
And finally, on the very outside, we have the star of the show, the visceral epithelial cells, which are better known as podocytes.
Podocytes are just fascinating cells. Podocyte literally means foot cell. And that's because these cells sit on the outside of the capillary, and they send out these long, finger-like projections called foot processes that wrap around the capillaries.
They interdigitate, like lacing your fingers together.
Exactly. And the space between those interdigitating fingers is bridged by a very thin, specialized membrane called the slit diaphragm.
I liked the analogy in Underwood that it's like a zipper.
It is exactly like a zipper. And the teeth of that zipper are made of specific, crucial proteins. You'll see names like nephrin and podocin. They are what hold the final barrier together. This is the ultimate fine-tuned control of filtration.
And this all leads us to the 2 fundamental ways this barrier selects what gets through. First, obviously, is size. Big molecules, like most proteins, get physically stuck.
Correct. That's the sieve function. But secondly, and this is absolutely crucial for understanding pathology, is charge. The entire barrier, the endothelium, the GBM, the podocytes, is covered in negatively charged molecules. The whole thing's an ionic.
And since most of the important proteins in our plasma, especially albumin, are also negatively charged,
They repel each other. It's like trying to push the 2 negative poles of a magnet together. They just bounce off. This electrostatic repulsion is a powerful force that keeps albumin in your blood where it belongs.
So if we see a significant amount of protein in the urine, a condition we call proteinuria, that tells us immediately that this sophisticated barrier has been breached.
Exactly. It is the absolute hallmark of glomerular failure. Either the magnet has lost its negative charge or the zipper has physically broken. Something has gone wrong with that barrier.
Okay. Now, once the fluid, now called filtrate, gets through this filter, it hits the tubules. And the numbers here are just mind-boggling. Underwood mentions that the glomeruli filter about 180 liters of blood plasma every single day.
But you only pee out about, 1.5 liters.
Which means the tubules are reabsorbing more than 99% of all that fluid and all the valuable stuff in it. That is an incredible, incredible workload.
It is. It's the critical distinction between bulk filtration in the glomerulus and precision reabsorption in the tubules. The proximal tubule does most of the heavy lifting. It reabsorbs the vast majority of sodium, water, glucose, amino acids right out of the gate.
And because it's doing so much active transport, all that pumping of stuff back into the blood, it must be incredibly hungry for energy.
Voracious. The cells of the proximal tubule are absolutely packed with mitochondria to produce ATP. But that enormous metabolic demand makes them the Achilles heel of the kidney. If the oxygen supply drops for any reason, say you're in shock from blood loss, the proximal tubule is the first part of the kidney to die. It literally suffocates.
We'll definitely come back to that when we talk about acute injury, but briefly, let's just touch on the other parts. The loop of Henle.
The loop of Henle is all about concentration. It's this brilliant countercurrent mechanism. It dips deep into the very salty inner part of the kidney, the medulla, to create a massive salt gradient. This is what allows us to reabsorb water later on and produce concentrated urine.
It's why we don't have to drink 180 liters of water a day just to survive.
Exactly. And then you have the distal tubule and the collecting duct.
The fine-tuner.
The fine-tuners. This is where hormones come into play. Aldosterone works here to fine-tune sodium reabsorption, and ADH, or antidiuretic hormone, works here to control water reabsorption. They make the final, precise adjustments to determine the final composition and volume of the urine.
Before we move on to the diseases, we have to mention one more structure, the juxtaglomerular apparatus, or JGA, because this is kind of like the brain of the whole operation, right?
In a sense, yes. It's a specialized sensing mechanism. It's located right where the distal tubule loops back and brushes up against its own glomerulus. And it has this special group of cells called the macula densa.
Which literally tastes the salt in the tubular fluid.
It does. It senses the sodium chloride concentration in the fluid passing by. If the salt level is low, it makes an assumption. It assumes that blood pressure must be low, and therefore filtration is low.
And it sends a signal.
It signals the JGA to release an enzyme called renin into the bloodstream.
And renin kicks off that whole famous cascade, the renin-angiotensin-aldosterone system, that constricts blood vessels and makes the body retain salt and water, all to boost blood pressure.
Exactly. And this creates a direct, powerful link between the kidney's function and your systemic blood pressure. It's a crucial closed loop. The kidney is actively controlling the volume and pressure of the very ocean that it swims in.
Okay, so we have the machinery, the high-pressure filter, the reclamation plant, the sensor. Now let's break it. We're going to start with glomerular diseases, the filter under siege. The texts do a great job of dividing this chaos into two major clinical syndromes, nephrotic and nephritic. I remember struggling to keep these straight, so let's really clarify the difference.
Using the clinical syndrome approach is the best way to categorize the chaos. It groups diseases by how they present, which is incredibly helpful. Let's start with nephrotic syndrome.
Okay, nephrotic. The O is for, what's a good mnemonic?
Think protein, or even open. The filter is wide open and leaky. The absolute hallmark of nephrotic syndrome is massive proteinuria. We're talking more than 3.5 grams of protein lost in the urine per day.
That's a huge amount of protein to be losing.
It's a catastrophic amount. In classic nephrotic syndrome, the filter isn't necessarily inflamed, it's just fundamentally leaky. That charge barrier we talked about, it's gone. The size barrier, it's compromised. So albumin, the main protein in the blood, just pours into the urine.
And when you lose all that albumin from your blood, you lose the oncotic pressure that holds water inside your veins.
Correct. So fluid leaks out of the blood vessels and into the surrounding tissues. The patient swells up. They get severe generalized edema, puffy eyes, swollen ankles, fluid in the abdomen.
And then there's a weird finding. They also get hyperlipidemia, really high levels of fat in the blood. Why is that?
It's the liver trying to compensate. The liver senses the dangerously low protein levels in the blood and it goes into overdrive, trying to synthesize new proteins, including albumin. But in the process of ramping up protein synthesis, it also churns out excess lipoproteins.
So to recap nephrotic, a very leaky filter, massive protein loss, low albumin in the blood, which leads to severe swelling, and high lipids.
And crucially, usually not much blood in the urine. That's a key difference. Now let's contrast that with nephritic syndrome.
Okay, so nephritic. The I in nephritic is for inflammation.
That works perfectly. Think inflamed. In nephritic syndrome, the glomerulus is angry and reactive. It's not just letting things through. It's clogged up with inflammatory cells, neutrophils, macrophages, lymphocytes.
And all this inflammation is actually damaging the capillary walls, tearing holes in them so badly that whole red blood cells can spill out.
Exactly. So the hallmark here is hematuria, red blood cells in the urine. It's often described by patients as cola-colored or smoky urine because the red cells get damaged and twisted as they're squeezed through the broken filter. We call them dysmorphic red cells.
And because the filter is all clogged up with this inflammatory gunk, the overall filtration rate just plummets.
Right, which leads to oliguria, a very low urine output. And because you aren't filtering fluid out, you retain it. That fluid retention leads to hypertension. So nephritic syndrome is blood in the urine, high blood pressure, some mild edema, and a ton of inflammation.
Okay, so we have our two main buckets, leaky versus inflamed. But what is the underlying cause of all this? Robbins goes really deep into the immune mechanisms.
The primary driver for most forms of glomerulonephritis is immune complex deposition. It's pretty simple, really. Your immune system creates antibodies. These antibodies bind to antigens, either foreign ones like a bacteria or your own self-antigens, and they form these clumps called immune complexes. These clumps then get stuck in the filter.
And where they get stuck and how they form really matters for the diagnosis, doesn't it?
Crucially, the complexes can form in situ, which means the antibody travels to the kidney and finds an antigen that is already sitting in the glomerulus and binds to it there. Or they can form in the blood first. We call these circulating immune complexes, and they just get passively trapped in the filter like debris in a storm drain.
Let's look at some specific diseases to see this in action. Let's start with the classic nephrotic syndrome in children. Minimal change disease.
The name really tells the whole story. If you take a biopsy of the kidney and look at it under a standard light microscope, the glomeruli look, well, normal. You see minimal change.
But the child is incredibly sick. Puffy, retaining water, and dumping massive amounts of protein in their urine. So something is clearly wrong.
You have to look deeper. If you use a powerful electron microscope, you see the truth. Those podocytes we talked about. With the little foot processes, the foot processes have effaced. They've flattened out and fused together.
The zipper is completely broken.
Exactly. The intricate slit diaphragms are gone. It's thought to be triggered by a release of cytokines, maybe after a viral infection or an immunization, that directly injures the podocytes. The good news here is that it usually responds dramatically to steroids. You suppress the immune system, the podocytes heal, and the foot processes grow back.
Now, what about in adults? The texts say that membranous nephropathy is a common cause of nephrotic syndrome.
Membranous is a very different mechanism. Here we have autoantibodies that are targeting a specific antigen located right on the podocyte itself, most commonly, a receptor called the PLA2R receptor.
So this is an in situ immune complex formation, and it creates these deposits that sit under the podocytes on the outer side of the basement membrane.
Right. We call them subepithelial deposits. Over time, the basement membrane tries to grow over and bury these deposits. On a special silver stain, this looks like little spikes of new membrane growing up between the deposits. Spikes on a silver stain. That's a classic board exam finding. And all of this damage makes the capillary wall thick membranous and very leaky, which gives you nephrotic syndrome. But unlike minimal change, this tends to be a chronic, slowly progressive disease that doesn't respond as well to steroids alone.
Okay, let's switch buckets over to nephritic, the inflamed one. The classic textbook example is the child who had a strep throat infection a few weeks ago.
Acute post-infectious glomerulonephritis. This is the prototype. The child's immune system ramps up to fight the streptococcal bacteria. It creates a ton of circulating immune complexes, strep antigen bound to antibody. These travel to the kidney and get lodged in the glomeruli.
And where they lodge, they call in the cavalry.
They activate complement and recruit neutrophils. The glomerulus becomes hypercellular. It's just packed with inflammatory white blood cells. These cells release enzymes and reactive oxygen species that physically damage the capillary walls.
And if we look with the electron microscope again, we see these characteristic subepithelial humps.
Those are the big, lumpy deposits of the immune complexes. Because the glomerulus is so inflamed and clogged, the GFR, the glomerular filtration rate, drops suddenly. So the child presents with the classic nephritic picture. Blood in the urine, high blood pressure, and puffy eyes.
But the prognosis is usually good.
Yes. In children, the prognosis is excellent. The immune system eventually clears the complexes, the inflammation subsides, and the kidney heals itself completely in most cases.
But that's not always the case with nephritic syndromes. There's one that sounds particularly nasty. Anti-GBM disease.
This is a different beast altogether. This is not about immune complexes getting stuck. Here, the body makes an antibody that directly attacks a component of the glomerular basement membrane itself, specifically that type 5E collagen we mentioned earlier. It's not debris in a drain. It's a targeted missile strike on the filter's foundation.
And the pattern you see on immunofluorescence is completely different, right?
Yes. Because the antibody is binding evenly all along the entire length of the basement membrane, you see a smooth, continuous, linear pattern of fluorescence. It looks like someone painted a glowing line along the capillaries. Contrast that with the lumpy, bumpy, granular pattern you see in the immune complex diseases we just discussed.
And what does this do clinically?
It's aggressive. It causes severe inflammation and, very characteristically, crescent formation.
Crescents? What are those?
When the damage is this severe, the Bowman's capsule, the cup that holds the glomerulus, fills up with proliferating cells, macrophages, and fibrin. This mass of cells compresses the glomerular tuft into a crescent moon shape on the slide. Seeing a crescent is a very bad sign. It means the glomerulus is being actively destroyed. It can lead to rapidly progressive renal failure. This is a true medical emergency.
Wow, okay, that covers the high-pressure filter pretty well. But what happens when the pipes downstream get clogged or poisoned? Let's move to the tubulointerstitial diseases.
The most important and common entity here is acute tubular injury, or ATI. You'll also often hear it called by its older name, acute tubular necrosis, or ATN.
And Robin says this is the single most common cause of acute kidney injury, especially in hospitalized patients.
By far. And it almost always stems from one of two major culprits, ischemia or toxicity.
Ischemia, meaning a lack of blood flow and oxygen?
Exactly. Remember the proximal tubule, the one that's an energy hog with all those mitochondria. If a patient goes into shock, if their blood pressure plummets from trauma, sepsis, or a massive heart attack, the kidney will try to protect itself by shunting blood away from the outer cortex. The proximal tubules starve of oxygen. They die.
And the other cause is toxicity.
Direct poisons. This could be exogenous toxins, so things from outside the body, like certain drugs. Gentamicin is a classic example, or the contrast agents used for CT scans, or heavy metals like mercury. Or it could be endogenous toxins, poisons generated from inside your own body.
I mean like myoglobin.
That's the perfect example. If you have a severe crush injury or a condition called rhabdomyolysis where your muscles break down, they release myoglobin. Myoglobin is directly toxic to the tubular cells, and it also physically precipitates and gums up the works.
So whether it's a lack of oxygen or a direct poison, the end result is the same. The tubular epithelial cells die.
They die, they lose their polarity, and they slough off the basement membrane into the lumen of the tubule. Now imagine a pipe. If you strip the lining off the inside and all that debris falls into the center, it creates a plug.
An obstruction.
Right. That obstruction creates back pressure. The pressure from the blocked tubule pushes all the way back up to the glomerulus and stops filtration dead in its tracks. The GFR tanks. The patient stops making urine.
And if you're lucky enough to get a urine sample and look at it under a microscope, you see the evidence.
You see the famous muddy brown granular casts. These casts are basically compacted molds of the dead, sloughed off tubular cells. Seeing them is highly suggestive of ATI.
But the texts say this is often reversible. Why is that? How can the kidney recover from this?
Because, unlike the highly specialized podocytes in the glomerulus or the neurons in your brain, tubular epithelial cells can regenerate. As long as the basement membrane, the underlying scaffolding of the tubule, remains intact, the surviving cells can divide, migrate, and repave the tubule over a week or two.
But the recovery phase itself is dangerous, the polyuric phase.
It is extremely tricky to manage. The new cells grow back, but they're immature. They haven't relearned how to concentrate urine yet. The salt gradients in the medulla are gone. So the patient goes from making almost no urine to suddenly making liters and liters of very dilute urine.
So they can actually dehydrate themselves to death while they are supposedly recovering.
Precisely. You have to meticulously replace their fluid and electrolyte losses until the tubules mature and regain their fine-tuning ability.
Now, there's another important way the tubules get hit, and that's through inflammation. Tubulointerstitial nephritis, or TIM.
Yes, and this is distinct from ATI. ATI is toxic or ischemic cell death. TIN is an immune-mediated inflammatory reaction. It's more like an allergic reaction in the kidney.
And it's usually triggered by drugs.
Most commonly, yes. A whole range of drugs. Antibiotics like penicillins, NSAIDs like ibuprofen, and even proton pump inhibitors, the acid reflux medications. The drug can act as a hapten. It binds to proteins on the tubular cells and makes them look foreign to the immune system.
So the immune system then launches an attack against the interstitium, the space between the tubules.
You get edema and an infiltration of inflammatory cells, mostly lymphocytes and macrophages. But there's a specific clue here. Eosinophils. If you see eosinophils in the urine or on the kidney biopsy, you should be thinking very strongly of a drug hypersensitivity reaction.
And the treatment is pretty straightforward.
Stop the offending drug. If you catch it early enough, the inflammation resolves and it's reversible. But if it's not recognized, the chronic inflammation can lead to fibrosis, scarring, and permanent kidney damage.
Okay, let's talk about a straight-up infection, pyelonephritis.
This is a bacterial infection of the kidney parenchyma and the renal pelvis itself. And usually, it starts in the bladder and ascends up the ureters.
E. coli climbing the ladder from a bladder infection.
Exactly. It's much more common in females due to their shorter urethra, and in anyone who has some kind of urinary obstruction or, importantly, vesicoureteral reflux.
Acute pyelonephritis sounds miserable. High fever, chills, pain in the flank.
It is. And microscopically, you see what you'd expect. The interstitium is full of neutrophils, and so are the tubules. This leads to the formation of white cell casts in the urine. It can even form little microabscesses throughout the kidney tissue.
But the real long-term danger is chronic pyelonephritis.
Yes, this is the result of recurrent, persistent infections over many years. It's most often associated with an underlying anatomical defect like reflux, where urine flows backward from the bladder up to the kidney, carrying bacteria with it.
And over time, this repeated inflammation completely scars the kidney.
It causes large, irregular, coarse scars, particularly at the poles of the kidney. The calyces, the little cups that collect urine from the pyramids, become blunted and deformed. The whole kidney shrinks and becomes knobby. Underwood mentions the term thyroidization, where the tubules become atrophic and filled with proteinaceous material resembling the thyroid gland. This is a significant cause of chronic renal failure.
Okay, we've covered the filters and the pipes. Now let's talk about the blood supply itself. Vascular diseases.
You really cannot separate the kidney from the blood vessels. The kidney is a vascular organ through and through. It receives 20 to 25% of the entire cardiac output.
And there's this infamous vicious cycle between hypertension and the kidney.
It's the classic chicken or the egg scenario. Kidney disease causes hypertension because of the salt and water retention and the release of renin. But hypertension also directly damages the kidney. They feed off each other.
Let's start with benign nephrosclerosis. This is what happens with chronic, mild to moderate high blood pressure over many years.
The term benign is a bit of a misnomer because it can absolutely lead to renal failure eventually, but it's a very slow, insidious process. The high pressure physically pushes plasma proteins into the walls of the small arterioles, a process called hyaline arteriosclerosis. The walls get thick, glassy, and pink on the slide.
It's like the vessel is forming a callus to withstand the pressure.
That's a good way to think about it. But as the wall thickens, the lumen, the opening, gets progressively narrower. Less blood can get through to the nephrons.
So the kidney is slowly being starved of oxygen over decades.
Yes, it's a state of chronic ischemia. The glomeruli and tubules slowly atrophy and are replaced by collagen. The kidney shrinks. On gross examination, the surface loses its smooth appearance, becomes finely granular, with a texture like grain leather.
Grain leather. I love these classic pathology descriptions. Now what about the opposite end of the spectrum? Malignant hypertension.
This is a medical emergency. This is when the blood pressure is sky high, like 200 over 120. At this level of pressure, the vessel walls don't just thicken, they undergo necrosis.
Fibrinoid necrosis.
Yes, the wall literally dies and gets infused with fibrin. The smooth muscle cells in the vessel wall proliferate rapidly, trying to contain the damage, and they lay down in layers, like an onion. This is called onion skinning. This process completely chokes off the blood supply. You get these little pinpoint hemorrhages on the surface, creating a flea-bitten appearance. It's a catastrophic vascular failure.
Before we move to the final common pathway, we have to briefly touch on thrombotic microangiopathy, things like HUS and TTP.
This is fundamentally a clotting disorder that affects the small vessels. The endothelium, the delicate inner lining of the vessels, gets damaged, often by a toxin like the one from E. coli 0157. This injury causes platelets to start sticking and forming little clots, or thrombi, right there in the capillaries of the glomerulus.
And as the red blood cells try to squeeze past these little clots,
They get sheared apart, literally sliced. On a blood smear, you see these fragmented red cells called schistocytes, or helmet cells. Meanwhile, these clots are blocking up all the glomeruli and small vessels, leading to sudden acute renal failure. It's like a microshredder has been turned on inside the kidney.
So we've talked about all these different insults, immune attacks, toxins, high pressure, infections, clots, but they all seem to lead to the same dark place, chronic kidney disease or CKD.
The final common pathway. This is one of the most important concepts in all of nephrology. Why does kidney disease so often progress even if the original cause is treated and gone? Say you fix the reflux surgically, or you cure the nephritis with immunosuppressants. Why does the kidney continue to fail years later?
It's that concept of adaptive hyperfiltration, right?
Precisely. Let's say you start with your full complement of 2 million nephrons. A disease comes along and knocks out half of them. The remaining 1 million don't just continue working at their normal pace. They adapt, they hypertrophy, they get bigger, and they work much, much harder to filter the same amount of blood to keep your creatinine normal.
They're picking up the slack for their fallen comrades.
But there is a terrible cost. To filter more blood They had to increase the pressure and flow inside their own glomeruli. This state of glomerular hypertension and hyperfiltration over time is itself damaging. It physically injures the podocytes and the endothelium of the surviving nephrons. They eventually scar down and die a process called glomerulosclerosis,
So now you have even fewer nephrons.
which means the remaining ones have to work even harder. It's a vicious, self-perpetuating downward spiral. The very adaptation that keeps you alive in the short term is what destroys the kidney in the long term.
And the end result of this process is the end-stage kidney.
Morphologically, at this point, it's often impossible to even tell what started the process. The kidney is small, shrunken, fibrotic, and heavily scarred. The glomeruli are completely glassed over and useless. We say they're hyalinized. The tubules are gone. It's just a wasteland of scar tissue.
And clinically, this is the state of uremia, the total failure of all those critical functions we listed at the very start.
Right. It connects right back to the chemical engineer role. You see failure in every domain. First, excretory failure. You can't get rid of nitrogenous waste products like urea and creatinine. This buildup, called azotemia, is toxic. It causes nausea, vomiting, confusion, uremic encephalopathy, and inflammation of the sac around the heart, pericarditis.
Then the fluid and electrolytes go haywire.
Total chaos. You retain fluid, causing severe edema and hypertension, and most dangerously, you retain potassium, hypokalemia. That can cause fatal cardiac arrhythmias. Your heart can just stop. You also can't excrete acid, so you develop a metabolic acidosis.
And finally, the endocrine failure. This is often missed, but it's devastating.
Absolutely. The kidney makes the hormone erythropoietin, or EPO, which tells your bone marrow to make red blood cells. No functioning kidney, no EPO. You develop a severe, debilitating anemia.
And it plays a huge role in vitamin D.
The kidney performs the final activation step for vitamin D.
Yeah.
Without active vitamin D, you can't absorb calcium from your gut. Your blood calcium drops. Your parathyroid glands then go into overdrive trying to compensate, and they start stripping calcium from your bones. This leads to a complex bone disease called renal osteodystrophy. Your bones become brittle and weak. It is a total systemic collapse.
It really is. It shows you just how much the kidney is doing for you silently, every single second. We should probably briefly mention cystic diseases, as they are a significant genetic cause of CKD.
Yes, and autosomal dominant polycystic kidney disease, or ADPKD, is the big one.
Hmm.
It's actually one of the most common single-gene disorders. It's a defect in the PKD1 or PKD2 genes, which code for proteins that are part of the primary cilia on tubular cells.
And the cilia are supposed to act like little antennae, sensing the flow of fluid in the tubule.
That's the idea. And when that sensing mechanism is broken, the cell growth and fluid secretion regulation goes haywire. The tubules start to balloon out and form these massive cysts. But unlike the shrunken end-stage kidney we just described, these kidneys become absolutely massive. They can weigh several kilograms each, completely replaced by these fluid-filled cysts.
But they can function for a surprisingly long time.
They can. Patients are often asymptomatic until their 40s or 50s. But eventually, the cysts compress and destroy the remaining normal kidney tissue, and renal failure sets in.
And we should contrast that with nephronophthisis.
Right. This is a very different disease. It's a group of genetic disorders that are a leading cause of kidney failure in children and young adults. Here you get cysts, but they're concentrated at the junction of the cortex and medulla. And in this disease, the kidneys are characteristically small and shrunken, with a lot of tubulointerstitial fibrosis.
So we've covered a lot of ground today, from the incredible elegance of the podocyte slit diaphragm to the crude brutality of an onion skin vessel.
And I think the overarching theme has to be that interconnectedness. The kidney is not a collection of spare parts you can swap out. It's a single, integrated ecosystem. Damage one part, and you inevitably damage the rest.
What really stands out to me is that regulation versus volume idea we started with. We think of the kidney as a volume manager. It makes urine, but it's really a master chemist.
The chemical engineer. And when the engineer is off the job, the internal chemical environment of the body becomes toxic and completely incompatible with life.
And for you, listening, the big takeaway has to be the importance of the clues. Because the kidney works in silence, we have to learn to listen for the whispers.
And that means looking at the liquid biopsy. A simple urinalysis. Is there protein? That points to the glomerulus. Is there blood? Is there sugar? Are there casts? Muddy brown casts tell you one story. White cell casts tell you a completely different one. These are the distress signals from a failing system.
And of course, monitoring blood pressure.
Absolutely. Hypertension is both a cause and a consequence of kidney disease. Controlling a patient's blood pressure is probably the single most important thing you can do to protect their remaining renal reserve.
So here's a final provocative thought for you to chew on as we wrap up. We talked about how the kidney hides its damage so well. You can lose 70, maybe even 80% of your total function before your standard creatinine blood test really starts to skyrocket into the abnormal range.
It's called the creatinine blind spot.
Exactly. And it just makes me wonder how many of us are walking around with 60% function or 50% and have absolutely no idea. We're relying on these crude lagging markers like creatinine, but by the time they change, so much irreversible damage has already been done. It really emphasizes that the future has to be in finding better, earlier biomarkers. We need to be able to hear the kidney screaming for help before the whole factory is on fire.
That is the frontier of modern nephrology, moving from a reactive footing to a proactive one.
Well, on that slightly terrifying but also motivating note, we're going to wrap up this deep dive.
And if you want to actually see the spikes, the humps, the crescents, and the casts we've been talking about, please go back to Robbins chapter 20 and Underwood chapter 21. The images in those chapters are absolutely essential to lock these concepts in.
Thanks for listening. Keep those filters clean, and we'll see you on the next deep dive.